Introducing Dr. Luke Johnson, who is here with us virtually. So, Dr. Johnson is Associate Professor of Dermatology and Pediatric Dermatology at the University of Utah. He earned his MD from the University of Pittsburgh and then went on to complete dermatology residency at Texas Tech, and then also completed his fellowship in pediatric dermatology at OHSU. He is deeply committed to teaching. He regularly gives lectures to medical students as well as dermatology and pediatric residents. And a fun fact, he co-hosts a dermatology podcast called Dermosphere, and he encourages everyone to give it a listen. Episode 172 was just released this week. Outside of work, his interests include board games, long walks on the beach, and tretinoin, which I think we might agree is everyone's favorite. We are really excited to learn some clinical pearls from him today, so please give me a warm welcome in welcoming Dr. Johnson.
Hi, everybody. I hope you can all hear me and see the screen okay. I'm told that things have been good. Thanks for the invitation. I'm excited to talk to you guys. I been doing this podcast, like was mentioned, for 6 years now. So a lot of my talks these days are drawn from stuff I've learned while doing the podcast, including this talk. I provided some ideas about what we could talk about and was told that inpatient stuff or isotretinoin stuff sounded good. So I smushed the two together. I'll just kind of go until we hit 11:50 and then it'll stop. We might not get through all the slides, but that's okay. Obviously, let me know or bring up some questions if they come up, assuming somebody else will monitor any chat that goes on. No one's really paying me generally. I co-host this podcast, but no one's really paying me for it. Please give it a listen, though we have had a couple educational grants from pharma, which shouldn't impact this talk. Also, we get donations from listeners like you. So if you'd like to donate to the podcast, there's a QR code. Okay, so we're going to start with inpatient stuff. And again, this is articles that I ran across while doing the podcast. Since we've been going for 6 years, sometimes I wonder if it's truly updates anymore, since some of the articles are, 6 years old, I guess, but still stuff that I have found valuable. We're going to learn stuff that's appropriate for inpatients. Okay, and I'm a pediatric dermatologist, but I'll talk about some adult stuff too. So first of all, etanercept for pediatric SJS. So that's from this article here, which was published in 2020. And at the time of publication, it had been shown to be at least useful for at least some published adult cases of SJS, including a case series of 10 and retrospective clinical trial, tough to do with SJS, at the time of this publication. So this study was just 4 patients. It was retrospective, and they all did well. So they were either dosed at 0.8 mg per kg, which is the psoriasis dose of this medicine, or they were given the adult dose, which is 50 milligrams. 2 patients just got a single dose. 2 of their patients were given an additional dose because they were continuing to progress. They noted 1 patient in particular, an 18-year-old girl. I suppose you could argue whether or not that counts as pediatric, but apparently she had an excellent response, and they attribute that to the speed with which the etanercept was given. And so it was at day 1. Here's a table. So the little triangle or diamonds are when etanercept was given. So you can see this patient number 3 is the one who just did so good. Everybody else did pretty good. Some representative photographs here. I think most of us have seen SJS and TEN. It's a long and unpleasant experience for everybody. And I think this improvement and this timeline is, a little bit faster than you would see otherwise with some of our other therapies. But again, retrospective, so they're not really able to comment on it. So they feel like it works fairly quickly with decreased erythema and arrested progression within 24 to 36 hours. And they recommend that if you're going to do this, that you recommend or that you consider a second dose at the 36 to 48 hour mark if it's still getting bad. So if the patient has fevers or if they've got erythema or edematous lesions would suggest ongoing inflammation. They do note that this is a pretty safe one. No adverse effects were seen in their 4 patients, but compared to some of the other stuff we have, this might be a good option. So we have a protocol at the University of Utah, and big shout out to my partner in pediatric dermatology, Dr. Sarah Cipriano here at the U, who came up with this protocol. So this is for pediatric SJS. So if it's just SJS, which, as you'll recall, is like 10% of the body surface or less, etanercept isn't on there. We use cyclosporin or we use prednisone. And then for the overlap syndromes or for TEN, so if it affects a small amount or larger of their body, then etanercept is there as an option or cyclosporin, but note that prednisone isn't. I feel like prednisone is pretty well on the outs when it comes to SJS or for TEN treatment in most places now. And etanercept doesn't really have any particular precautions. If the patient is septic, I suppose you don't want to give it, or if they have some other significant infection, but you wouldn't want to give cyclosporin in those cases either. So I feel like etanercept has a larger patient population for which it would be appropriate. We do have etanercept available in our pharmacy here. Only dermatology gets to use it. It's sort of a break glass in case of emergency sitting there for us. So perhaps it can work for Rime as well. So that's from this article here from 2021 in JAMA Dermatology. So Rime, as we probably remember, stands for reactive infectious mucocutaneous eruption. I'm sure the residents don't remember because they've all been told Rime from day one, but some of the other attendings who are roughly my age remember when it was briefly MIRM, mycoplasma-induced rash and mucositis. And before then, we often just called it SJS. So there was a lot of confusion in some of the older literature where these patients were lumped into SJS treatments and outcomes, but it's just not true. We now know that it's a different entity. So this was a retrospective review again of 6 patients with Rime. These were age 5 to 13. No 18-year-olds in this one. This is real good ages for Rime, by the way. And they gave etanercept if the patient was sort of getting worse. If they showed up to the hospital and their condition had already stabilized or was getting better, then they wouldn't bother. And similar to the previous study, they would redose them with etanercept if they were still getting worse at the 48-hour mark. Similar dosing. 5 of their 6 patients noticed improvement within the first 24 hours of receiving etanercept. Again, this is not a controlled trial, so maybe they would have got better anyway, but it still seemed relevant to the authors. Their eyes were the first thing to get better, and then within 3 days, patients were able to advance their diet, discontinue their as-needed pain medications, and their average hospital stay was 6 days, which the authors state was better than that reported in the literature for other treatments like those you see here. I don't know if you guys have had this issue over the past 2 weeks, but just in the past 2 weeks, we have had a rash of Rime in our hospital. I think we've had 4 or 5 patients with this or EM major. So it certainly seems to be Rime season. And I feel similarly for etanercept for this condition. It's got a lot of safety compared to some of the other options that we can use. So some representative photographs. Okay, so the next subject is kind of tough to talk about, but I think it's an important part of our role in society as physicians and also as dermatologists and as pediatric dermatologists to be able to recognize cutaneous manifestations of child abuse and neglect. So that's this article here, which is one of these CME articles from the JAD. And so these authors state that, we as dermatologists are mostly an outpatient specialty, and there are other doctors and other healthcare professionals who are a lot better at than us at figuring out whether or not a child was actually abused and then what to do about it. So they emphasize that our role is really to figure out if we have suspicion for it, and if so, to get children to the emergency room as expediently and as definitively as possible. So they say, for example, don't ask the parents to take the kids to the emergency room because if they're the ones abusing the child, then they might not go to the emergency room and instead go home and keep abusing their child. So you're supposed to get an ambulance to take them over there. Or I've sent 1 or 2 patients over to the ED from clinic, which is attached to the children's hospital, and I have one of my MAs walk the family over there to make sure they get there. And then, of course, We are mandated reporters. If you have any suspicion, you're supposed to talk to whatever your version of CPS is. So that was the biggest takeaway for me, sort of clarifying our role. And then another important takeaway is this concept of sentinel injuries. So sentinel injury is an injury that suggests that this child is at increased risk of further abuse because this injury actually represents abuse, even if the injury itself appears rather minor. And we in dermatology and in pediatric dermatology, we look at kids' skin all the time and we see lots of bruises and injuries. They get all banged up because, most kids are pretty active. So our eyes, I think, tend to skip past some of those marks that we see. But especially if you've got an infant, don't let your eyes just skip past it, especially a young infant. So any bruise in a pre-mobile infant counts as a sentinel injury, according to these authors. So you might recall that as babies start to learn how to walk, oftentimes they'll start by cruising, where they hold on to furniture and stuff and then kind of toddle along. Usually that's around 9 months of age. And so if you're not cruising, you shouldn't be bruising. And if you are having some bruising without cruising, that deserves our attention. It doesn't mean it's abuse, but it's not something they're supposed to have. So they could have some bleeding disorder, they could have leukemia. Regardless, they need to be evaluated in the emergency room. But once you do cruise, then you do start bruising. So normal spots are the places where you might guess, where kids get knocked around by bumping into stuff and falling on their faces. But these authors point out that you don't usually bump your cheeks or your eyes if you're learning how to walk, and you should be extra suspicious if the bruising is bilateral, if it's clustered, if it's patterned, meaning it kind of looks like an object or something, or if it's on multiple planes of the body. Because if I fall down and I hit my forehead, then the back of me doesn't also get bruised. They have a mnemonic here, which was developed by other authors that they say is fairly sensitive and specific in detecting non-accidental trauma in children. It's a cumbersome mnemonic, however. 10 4 faces P is the mnemonic. So as you can see, 10 is spelled out T-E-N. Torso, ears, and neck are uncommon spots. Kids usually get knocked around on the extremities with their normal activities. And then 4 is the age. So any child under 4 years of age with bruising on these locations should be raise your concern. These are all images from this article that show mostly pictures of abuse. You would not expect these sorts of bruises to just kind of happen by accident. And then faces P is specific areas that should raise your concern, things that usually just don't get injured unless someone's doing it deliberately. So we don't think about the frenulum very much in dermatology, at least I don't, but this little tissue that holds the lip to the gingiva or the tongue to the bottom of the mouth. If we've got a tear there, that's pretty suspicious. The ears again, the angle of the jaw, cheeks and eyes again, and then this pattern bruising again, and petechial bruising is suspicious. So some more pictures, just it helps us to look at them, even though it is kind of tough. Cheeks, not normally something that gets knocked around. Eyelids. This is a patterned bruise, so you can imagine an object like an electrical cord or something could have made this mark. So again, our role is to triage, to get people into the emergency room. And the emergency room, they'll usually be the ones conducting these interviews. The authors emphasize that our role is to get kids there where they can be worked up by people who have been better trained than most of us have been. But if you want to interview the child, it's reasonable to do if they're age 3 or more. If they're under age 3, they say don't bother, it's not at all reliable. Be open and non-judgmental. So this is, I think, useful advice for all aspects of life and our profession. There's a great quote by Thoreau: be curious, not judgmental. You don't really know what's going on. And even if the kid is being abused, it might not be that parent who's with them, and they might not know about it. So open and non-judgmental. It's not our job to find proof of abuse or to find a perpetrator. The authors also emphasize that we should be aware of our own biases. It turns out that physicians more commonly report abuse in minorities and low-income patients, but abuse can happen to anybody. I found that some of their quotes were helpful to come up with ideas about how to talk to families, parents in ways that are curious but not judgmental, such as, "Can you tell me what happened here?" Or, "I noticed some marks on her arm. Can you tell me more about them?" Rather than, "It looks like somebody hit you here." And then if you're trying to get them to the emergency room, "It is not normal for babies this young to have any bruises. These bruises could be the result of a bleeding issue or from some injury that you are not aware of. Either way, your baby needs immediate evaluation in the ED, and we're going to get an ambulance to take him there." And then if you were trying to look for some language when you're making a report to CPS, you might say, "When children tell us that someone has caused a mark on their skin, we are mandated by law to make a report to Child Protective Services. They may contact you if they choose to follow up on the report." So I feel like that's fairly non-judgmental. You're not saying, CPS is coming after you guys. They might choose to follow up on the report. It's very non-judgy. Um, that's all for this difficult topic. Again, feel free to chime in. I do this podcast every 2 weeks, so I'm used to talking to myself. I assume you guys can still hear me. Okay, the next concept is totally different and is an extremely rare exotic peds derm diagnosis that I have never seen, but I found this article interesting. So this was actually one of those photo quizzes from JAMA Dermatology. And this concept, congenital disseminated pyogenic granuloma, this was the representative case. It's a 3-month-old boy. He had these lesions present at birth. Again, extremely rare. 13 cases reported in the literature, they said. So probably you'll never see it, but if you do, hopefully you will think back to this moment and something will trigger in your brain that says, "Man, I think maybe I heard about something once that kind of looks like this. Maybe I'll dig into it a little bit more." And sometimes that's all your brain needs in order to find the right diagnosis and the right treatment. Don't really know why kids get this. Fortunately, these go away at 9 to 16 months. Unfortunately, you can have really bad side effects from them. You can get these pyogenic granulomas elsewhere in the body as well, the viscera, the CNS, like our more run-of-the-mill pyogenic granulomas. They can bleed, and so if they bleed into the CNS, the results can be, quote, "devastating," according to the authors of this study. Also, like our more run-of-the-mill PGs, the histology is distinctive. So if you do find somebody who has this, they need this imaging to figure out what to do. Here's the histology. I'm not a dermatopathologist, but I assume this is distinctive. Those dermatopathologists in the audience, I'm sure, are nodding their heads right now. Apparently, this is a dermal lobulated capillary proliferation. It is CD31 and SMA positive, and it is negative for D240, which I'm pretty sure is a lymphatic marker, and negative for GLUT1 residence. Recall, GLUT1 is a marker specifically for infantile hemangiomas. Not much else in dermatology is positive for GLUT1, but placental tissue is. So your differential diagnosis for disseminated pyogenic granuloma, if you think something is disseminated pyogenic granuloma, there's a decent chance it's just multifocal infantile hemangiomas, because that's way more common. We see these, I mean, not every day, but fairly routinely. Difference is, though, that these are not present at birth. They're not as dynamic, so they're not bleeding and changing as much, though they do change, as we know infantile hemangiomas do. These follow that typical course. They're a little bit more monomorphic, I feel, at least based on photographs. This is one of my patients, a fairly typical case, I think, of multifocal infantile hemangiomas, and like these things look weird compared to these. And these, again, histologically distinct. So if you want a biopsy, you'll get the answer that way. A couple other differentials that they mentioned, at least in the article: bacillary angiomatosis. It's an infection from these germs in immunosuppressed patients. Apparently, a Warthin starry stain can show clumps of bacterial rods. The dermatopathologist in my residency program referred to it as the worthless starry stain. Don't know if you all feel the same way. And you would not expect this in a newborn infant, of course. And then multifocal lymphangioendotheliomatosis with thrombocytopenia apparently is a thing. Again, I've never seen it. I always try to remember that it exists when I have a patient with multifocal hemangiomas because I want to remember the important things that I could hypothetically miss if I'm not thinking about them. But this one can also be bad because you can get these similar lesions present in the GI tract where they can hemorrhage, but they look a lot different than infantile hemangiomas, at least based on the photographs. These are a lot more blue-gray in appearance. Okay, acute inflammatory edema. I did not know about this until I read the article, but it seems to have gained some traction because our residents all seem to know what it is, so maybe y'all already know what it is. But just in case, um, it's from this article here, which I think was 2019. So yeah, hopefully it's gone around, made the rounds. So this was a case series of 15 patients. They were adults. And this is a pseudocellulitis, this acute inflammatory edema thing. So important for us to know. These were all real sick people. 80% of them were in the ICU. Those who weren't in the ICU had been in the ICU recently or otherwise were quite sick. And this looks like cellulitis. It's a pseudocellulitis. It was always on the thighs in all of their patients and often on the abdomen as well. Seemed to spare areas of pressure and skin folds, so maybe where the edema gets kind of squished out of those locations. Most of their patients had elevated BMI, and they were edematous. They had various other signs of volume overload. In histology, you see edema as well, papillary dermal edema, and even these edemophages that have been eating the edema. Yum, yum. They often had leukocytosis, which contributed to this being a pseudocellulitis, but most of the time, or at least all the time, in these authors' opinion, the leukocytosis was from the underlying diagnosis rather than from cellulitis. And so save them some unnecessary antibiotics and potential antibiotic related side effects. Tell the primary team this is acute inflammatory edema. Address the volume and positioning issues. Here are some photos from the article. So you can see the thighs are affected and the abdomen. And then they've got this photo showing that it gets kind of squished out of the inguinal fold. So we can take a look in there and see that if it were cellulitis, you would expect it to just be progressing up there. This is a nice little diagram that shows where they found it in their patients. So look, all of the back stuff in the middle of the back is spared, presumably because lying on a hospital bed smushes out the edema. Why might this happen? Well, of course, we don't know. But the authors postulate that you've got a patient who already has impaired lymphatic return, perhaps related to their elevated BMI, and they get acute volume overload, and that causes edema in their dermis, and that stretches and then tears the little connective tissue, and that torn connective tissue attracts some inflammation. Maybe. They say it could be analogous to inflammatory actinic purpura, which is pictured here, which you get shearing forces that cause breakage of the elastotic material in there, and then neutrophils come to investigate. These are all adult patients. I'm curious if we can find this in very many pediatric patients. We did have a patient in our service last week where a resident thought that they had this, but I was not convinced. But maybe some of you guys have like the best pediatric dermatology department in the country. Maybe you've seen some of this. Okay, bullous hemorrhagic dermatitis, another non-pediatric thing generally. So this is a study out of France that reviewed 94 cases of this condition, which I had never heard of before, sort of like acute inflammatory edema. And similar to acute inflammatory edema, it looks worse than it is. You can basically just not worry about it and tell the primary team it's okay. Here's a representative lesion. There are these dark vesicles or bullae. They look a little bit like angiokeratomas, probably not on dermoscopy, but at least grossly they do. Patients usually have just a handful, 10 or fewer, but in their cases, there were up to 100 of them in a particular patient. These occur on the extremities, usually in men, usually age 70 or over. These guys are all on anticoagulants. That's just related to why this shows up. It's pretty rare, but as I said, you don't need to worry about it. So they found 37 cases from the French pharmacovigilance database, and they also did a lit search for 57 additional cases for 94 total. Men outnumbered women by 2 to 1. You can see the average age here. And then they were all on these various blood thinners. Enoxaparin was by far the most common, and then other heparins and a few others as well. Onset was pretty variable within 6 hours to 30 days after starting the medication. And here are some pictures from the article. So you can see why this would be concerning if somebody was unaware of this entity in particular. Again, I am unashamedly not a dermatopathologist, but here's what it looks like on DermPath. So all these patients did fine. 12 of them maintained their heparin despite this, and they also did fine after the treatments were discontinued. These all faded away. The authors emphasize that this is pretty rare. We use lots of heparin, especially for our cardiology patients, and they only found 90 something patients. So you think about it in men age 70 plus, especially if they happen to be in the CICU or they have other reasons to have cardiac issues, you might consider just maintaining their medicine, especially if it's doing some good. Pathophysiologically, we don't really know what's happening. The authors speculate that aging and skin fragility has something to do with it, and also wonder about mechanical factors, like this one looks like maybe somebody was scratching it or something. You want to make sure it's not something else, so that's part of our job, just to look at it, make sure we're not missing something important. So the differential included leukocytoclastic vasculitis, heparin-induced skin necrosis, linear IgA, and then bullous pemphigoid plus bleeding because of your blood thinners potentially. The last of our inpatient articles is a review about retiform purpura. I'm going to move through it fairly quickly because it's a review, but I found that retiform purpura are sort of one of my weaknesses in dermatology. I don't know why, but I wanted to make sure I took a good look at this article from 2020. So they talked about these four specific causes of retiform purpura: calciphylaxis, cryoglobulinemia, livedoid vasculopathy, and ANCA-associated vasculitis. You're welcome for this picture. Penile necrosis due to calciphylaxis. The 1 year survival rate's 45%. This is not a good thing to have. First, you get pain, then the skin lesions develop. You can get penile or digital necrosis. The pathophysiology is calcium deposits in the vessel walls, and then you get thrombosis. A lot of these patients end up having 2 or more inherited thrombophilia polymorphisms if you look for them, which presumably contributes to the pathogenesis. For a long time, this was associated, almost purely with renal disease, but now we know there's this non-uremic form you can get, so not related to renal disease, and they seem to be triggered by drugs a lot of the time, chronic steroids. Sometimes we do that to people, warfarin, diabetes, and then liver disease as well. Deep biopsies are necessary to properly identify. So pictures, the one on the left is uremic, the one on the right is non-uremic. They look pretty similar, though in this particular case, the one on the left looks worse. So treat it, you can use sodium thiosulfate perhaps bisphosphonates in non-uremic disease. If they're on warfarin, you want to stop it because it can contribute. Apixaban and vitamin K are potentially emerging therapies. I think you guys have a great inpatient dermatology service. You guys probably know about this stuff. This article also included a bunch of flow sheets. They're mostly here for reference, but really good flow sheets if you're wondering about stuff like this, what to do about it. Cryoglobulinemia. What a weird one. So your B cells are making these immunoglobulins that happen to be a type that precipitates and form a gel at 37 degrees Celsius for some ungodly reason. Residents might be tested on the 3 subtypes, as you can see here. Clinically, you can see the sorts of things you might expect from this vaso-occlusive disorder. Retiform purpura, acrocyanosis like cold stuff, because these are cryoglobulins, including cold urticaria, livido, palpable purpura, and then you can get problems with your other organs because they're all getting clots in them. So the reason this might get triggered is from various infections like hepatitis B and C and HIV and then various lymphoproliferative disorders. So you just want to make sure you're looking for those. And then another nice flow sheet about what to do if you've had a patient with it. Of course, you want to treat the underlying disorder and then immunosuppress those B cells. They're not doing you any good right now. Livedoid vasculopathy is the next one they discussed. So this is a chronic, painful thromboocclusive disease with fibrin thrombi stuck in the vessels. I used to get this confused. I thought it meant the same thing as atrophy blanche, but I guess you can get atrophy blanche with other diagnoses as well. Probably venous stasis is the most common. But when you see those little stellate sclerotic atrophic papules of atrophy blanche, you want to think about this condition if they're on the malleoli on the dorsal feet specifically. This is a disease of young people. Yes, 32 is young, so is 45, darn it. Other associations with this condition are hypercoagulability. That's the most common reason to get livedoid vasculopathy. You can also get it from connective tissue disease, hepatitis, or paraproteinemia. The patient photographed here has a factor V Leiden mutation. Some more germ path for you germ path aficionados out there. And then, as I said, full of flow sheets. Treat it by getting rid of those clots with antithrombotics. In connective tissue disease, you might have some other options, and you can consider antiplatelet treatment as well. And then finally, ANCA-associated vasculitides. We probably remember there's 3 of them. Granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. Some of these used to have other names. They can look like lots of stuff. Look at all these things in the clinical manifestations. Things that I might forget are urticaria-like lesions, though I do remember that urticarial vasculitis is a thing. Erythematous papules and plaques like that photographed here. EM-like. Drugs can cause it too. Cocaine, so consider doing a urine drug screen, and then these other drugs that are usually not things that we're at least prescribing, but some of them are. Anti-TNFs and minocycline, perhaps. Rheumatology tends to drive the bus on these guys' treatments. They've got these induction and maintenance regimens, so I would certainly get them involved if they have not been involved already. Apparently, rituximab is changing the treatment landscape for these disorders. Okay, so that's all the inpatient stuff. So to recap, we talked about etanercept. You might consider it in pediatric SJS, TEN, and Rhyme. We remembered our role in child abuse and neglect. We can recognize congenital disseminated pyogenic granuloma if we ever happen to see it. Acute inflammatory edema, not cellulitis, don't be fooled. We learned about bullous hemorrhagic dermatitis. You can just chillax about it. And we learned about retiform purpura. Would anybody like to have a question or comment before we move on to the isotretinoin portion of the morning? I don't hear anything, so I assume that everything is still good and I can continue. And I didn't become frozen 30 minutes ago, and everyone else has been struggling to reconnect me. So let's talk about isotretinoin. One of my favorite drugs. I think it's a lot of our favorite drugs. So we're going to talk about it. Okay, so treat for 2 months past clearance. This seems to be an emerging treatment change over the past few years. The one we discussed in the podcast is from this article from 2021. So they talk about in this article how previous studies showed that acne recurrence after isotretinoin is associated with, so the chance of your acne coming back, even after you finish a course of isotretinoin, and I'm positive I'm going to say Accutane occasionally, I'm not being paid by the company, was associated with cumulative dose. If you were male, you were more likely to have recurrence. If you were younger, if it was more severe, and if you were treated for less time. So that was previous to this study. They said literature had shown these things are associated with recurrence. Their study was a retrospective case control series. So they looked back at their records and found 82 patients who recurred after a course of Accutane, and then 160 patients who did not. So those were the controls. And then they tried to figure out what was different between the two groups. And they only found 2 important differences. The patients who did not require a second course of isotretinoin were more likely to have received a higher cumulative dose, so about 160 mg per kg total versus about 130 mg per kg total. And they were more likely to have been, quote, clear for longer before discontinuing isotretinoin. So 2 months of clearance versus 1 month of clearance. In contrast to previous literature, they did not find an association with any of this other stuff. It's a small change, but ever since looking through this article, this is now my goal. I try to get patients to 2 months since they've of clearance before stopping, and ideally to 160 mg per kg or higher as well, though it seems, in talking to some other pediatric dermatologists and going to conferences and stuff, being clear for 2 months seems to be more important than the cumulative dose. I think the cumulative dose is still kind of important, but if somebody's been clear for 2 months and they're at 130, I'll at least offer them the option to go ahead and discontinue. What can we do to help with all the side effects that people get in isotretinoin? Well, perhaps we can use antihistamines. Look at this article. It's out of the Kathmandu University Medical Journal. Anybody else ever read anything from the Kathmandu University Medical Journal? So this work was building on a 2014 study that was published in the JEADV. So in that study, Lee et al. Showed that 40 patients on isotretinoin seemed to do better if they had an antihistamine on board. So these folks in Nepal wanted to further that particular study. There's Nepal, by the way. I wasn't quite sure. And this is what it looks like. Doesn't it look nice? If you think it might look kind of familiar, perhaps you will recall that Dr. Strange learned the mystic arts while visiting Nepal. So this was a single blinded study, so the patients knew what they were taking, but the investigators did not. They had 100 patients. They were taking isotretinoin at a dose of half a mg per kg per day. Tends to be a little bit less than we do here in the States, but this seems to be fairly common in a lot of other countries. And then they were also treated with this particular antihistamine, levocetirizine, at a standard dose. And what they found was that the patients who were on antihistamine in addition to isotretinoin had more improvement of their acne, and they had fewer adverse events. That's pretty cool. So specifically at week 12, patients in the antihistamine group had fewer acne lesions. They had decreased by 2/3 rather than half. There's a grading system for acne apparently called the Global Acne Grading System, or GAGS, which is a great name, but they had more improvement based on that if they had been on antihistamines, 51% versus 39%. They reported better patient satisfaction. Of course, just about everybody taking isotretinoin is satisfied by week 12 just because it's such a good drug, but more patients in the antihistamine group were very satisfied compared to merely satisfied. And interestingly, even though we sometimes associate antihistamines with drying out mucous membranes, patients in the antihistamine group had less dryness and pruritus, and they said fewer adverse events overall, though they didn't report p-values. Perhaps they submitted this article to the JAD, and the JAD was like, give us your p-values. And they were like, well, we don't have them. I guess we'll publish in the Kathmandu University Medical Journal. So it's hard to know if this is statistically significant or not, but still I find it interesting. Antihistamines are so safe and cheap. So this is the table. So the group on the left is the antihistamine group. The group on the right is not. You can see all of these highlighted spots were interesting because they were actually worse in the antihistamine group, which the authors did not comment on. Worse or the same, I guess I should say. But they do note that skin dryness and pruritus was better in their group. So I consider this occasionally. I don't recommend everybody on isotretinoin add an antihistamine, but if occasionally I'll have a family who's like, okay, tell us everything we can do to help prevent these side effects and get better as quickly as possible, then I'll mention it. And then sometimes I'll mention it if patients just aren't turning around like I would guess by month 2 or 3. Omega-3s might also be able to help our patients with isotretinoin and their side effects. So that was this article out of Iran. Look at all the stuff we're learning today, not only dermatology, but also geography. This is what Iran looks like, taken from one vantage. So another randomized, this one was randomized controlled trial, not just single-blinded. They had 118 patients, same dose of isotretinoin. These guys, some of them were supplemented with 1 gram of omega-3 fatty acids daily. And they had fewer xerotic adverse effects. They had less chylitis, less xerosis, less dry nose, less dry eye, but only at week 4. For some reason, only the dry eye was only significant when measured at the week 4 visit, but the rest was relevant the whole time. That's pretty cool. So what else do we know about omega-3s? Well, we can't produce them in the human body, so you must eat them. They are found in fish oils. According to the article, they are also found in plants. The internet helped me clarify which particular plants tend to have omega-3 fatty acids. No particular adverse effects according to the article, but according to some other sources, you can get a fishy taste from omega-3 fatty acids. You can have some GI upset, perhaps. You can get some eructation, which sounds saucier than it is. It apparently means burping. Eructation is the medical term for burping. I wondered about bleeding. I had a hard time finding any information about it, but I remember doing Mohs surgery as a resident, and patients who are on fish oil seem to just have more oozing even than patients on aspirin. But it seems like it's not medically significant based on the literature I looked up. So I will often add omega-3 fatty acids, 1,000 milligrams a day, for my patients on isotretinoin, especially if they mention that various things are dry. These authors report that omega-3 fatty acids might have some other benefits as well. There was this study out of JAMA Dermatology in 2015 showing that it decreased serum triglycerides specifically in patients taking isotretinoin. I guess it can increase HDL. It can help perhaps with depression. It's anti-inflammatory. The authors cite some evidence that could perhaps help with eczema or allergic diseases. It can help with dry eye, especially that related to contact lenses. Can it improve epidermal water loss? The authors cite some sources saying that it can, and even some preliminary slash weak data that says it can help against all of this other stuff too. Man, doesn't it make you want to just go out and buy some omega-3 fatty acids? Look, you can buy them at Walmart for $16. I'm not getting sponsored by Walmart. Okay, we got time for one more, I think, before we hit the 11:50 mark and open it up for some questions. This one's pretty important. I would guess it's important enough that you all probably already know this, but just in case, important enough to also mention. So, out of the JAD 2021. So, this was a big data study where they found 73,000 acne patients. 30,000 of them were on isotretinoin, 43,000 were antibiotics. They were the acne age range, and they compared these people to the general population. And they found that the general population was more likely to have a suicidal ideation or attempt compared to patients on isotretinoin. 1.5 times more likely. So people on isotretinoin are less likely than the general population to have this. Interestingly, isotretinoin patients were more likely to carry a psychiatric diagnosis when compared to the general population and to antibiotic acne patients. So here's specifically the prevalence of suicidal behavior in isotretinoin patients. So in the year prior to treatment, it was 0.22%. On treatment, it was 0.1%, so halved. And the year following treatment, though, it goes back even beyond baseline to 0.34%. Interesting. The author's conclusions were compared to the general population, acne patients prescribed isotretinoin were less likely to engage in suicidal behavior. So we've got a fair amount of evidence sort of arguing against the black box warning on the medication at this point. I talk about this to pretty much everybody I start on the medicine. I say there's this black box warning based on, in my opinion, the recent and best data we have currently. Patients taking the medicine are actually less likely to be suicidal. It's interesting to speculate as to why some of these numbers are the way they are. We don't know, of course, but perhaps patients on isotretinoin have a greater psychiatric diagnosis because they just have more contact with the healthcare system. They're required to see us every month after all, so there's more likely for somebody to get picked up and referred and diagnosed appropriately. Perhaps real bad acne can be associated with psychiatric conditions. The antibiotic acne patients had the same risk as the general population, but you can speculate that the isotretinoin patients just have worse acne in general. Perhaps just really bad acne causes some kind of systemic inflammation that can affect the brain. All of those are reasonable hypotheses. And then why these numbers? Why the ups and downs? Again, we don't really know, but some interesting thoughts are maybe they're happier because their acne is getting better, so they're feeling less suicidal. That would be nice. Also, again, they see us every month. So I kind of wish I saw everybody every month. It's so nice to see people that often. And so I wonder if just that connection there, every month they're talking to somebody who cares about this aspect of their lives, their skin, and they're doing something for it and they have hope. Perhaps that's somewhat related. And then maybe that's also related to the reason why it increases after they're done with their isotretinoin. They're not having that contact anymore. The authors of this study also mention what they call the lost hope hypothesis, suggesting that some patients with bad acne feel that after they get their acne under control, everything in their life is going to get better. They're going to have the romantic relationships that they always wondered about and get the job that they always wanted and stuff. But of course, acne is only one part of their whole lives. And so when they discover that some of the rest of that's not getting better, they might start feeling blue about it. Yeah, don't know, but interesting to speculate. Hey, I think we're at time, so I'm going to stop sharing and happy to take questions or comments from this illustrious group. I see people clapping. I don't hear it, but thank you.
Thank you, Dr. Johnson. That was great. I learned a lot. I hope everyone learned a pearl. I hope some of our residents here have maybe heard of acute inflammatory edema because I've mentioned it before, but I definitely learned something new, the antihistamines I've never heard of. So I'm curious if you have a particular antihistamine that you tend to recommend, or, I know you mentioned you don't always suggest it to patients, but curious about that.
Not really. I think they're mostly a class effect as long as you're using one of the new generation non-sedating ones. They use levocetirizine in that study. That seems like a fine choice. It's cheap.
Yeah, it's interesting because I would have expected, you would have more dry eyes and more dry mouth and more dryness.
I know. Kind of weird. The also why? Like why would antihistamines help? The authors do go into some detail in the study as to why it could be. Apparently, mast cells are involved in squalene production, and you can find them hanging around the sebocytes, and perhaps they could be contributing. Sometimes people's acne is itchy. Are mast cells partly related? I don't know. The human body's amazing. There's so much stuff we're still learning about. It's cool to be a doctor.
Any other questions or comments? Okay, well, thank you so much, Dr. Johnson. We'll all definitely check out your podcast. Thank you for speaking to us.
Of course. Thanks for the invite, guys.